Hello, Dr. Wisoff. Can you hear me?
Yes, Narent. Good morning. How are you today?
Thank you very much.
Or good afternoon, I should say. Yes, Narent. Good morning.
Going to afternoon. Good morning to you, Dr. Wisoff. Thank you very much for joining us. We're looking forward to your lecture. I'll just let's see. Stop my sharing. So great. Dr. Wisoff, you should be able to share your presentation. Thanks.
Okay, let's see.
Brilliant. Thank you. Dr. Wisoff, I'm streaming this on the YouTube. Are you okay with that? I can
Yes, not a problem. You can stream, you can record anything.
Fabulous. Thank you very much. So now it's 1:30 here. It's, I think, 8:30 in New York. So is it okay if I introduce you, Dr. Wisoff? And thank you very much. So thank you very much to everyone attending this lecture from Dr. Wisoff. As we know that craniopharyngioma is one of the toughest lesions for neurosurgeons to tackle, one of the toughest areas to manage for neurosurgeons, and it's a multidisciplinary management with multiple different options. It's very controversial as well. And there's no one else who knows of surgical and radical surgical treatment of craniopharyngioma more than Dr. Wisoff. So it's a real privilege to have such an expert to give us a lecture on it and share his vast experience and expertise on this subject. We have in our participants senior neurosurgeons attending as well. So I look forward to your questioning of Dr. Wisoff. I think it will be good to have ask Dr. Wisoff as tough a question as we can, because he's one that we can ask who's an expert who would be able to give us those answers. And once again, to all the participants as well, you are welcome to ask questions. You can put it on the chat box, then I will try to bring you to the microphone, time permitting. So Dr. Wisoff is a professor of pediatric neurosurgery and professor of pediatrics at New York University. He's well known around the world as one of the master pediatric neurosurgeons and master of craniopharyngioma neurosurgery. And so without further ado, Dr. Wisoff, if you would be kind enough to take us through your lecture. Thank you.
Thank you very much, Narent. It's truly an honor to be able to address the Masterclass and the nascent University of Pediatric Neurosurgery. Okay, let's see if we can get this to advance. There we go. So I always like to start this lecture by discussing my father. My father was a neurosurgeon, trained under Leo Davidoff, one of Cushing's residents, and ultimately was chairman of neurosurgery at the Albert Einstein Medical School at Montefiore Medical Center in New York City. Interestingly, he never talked neurosurgery with me until after I graduated medical school and was accepted into my training. But nonetheless, over the years, he had certain aphorisms, lessons that I learned that I think are applicable. He said that ultimately a neurosurgeon must be an optimist, and this comes down to surgical philosophy. He often would say that an experienced neurosurgeon is one who has seen his cured meningiomas recur, and I suspect in our field, an experienced pediatric neurosurgeon is one who has seen his cured craniopharyngiomas recur. And this requires us to have a discussion of overall survival and disease-free or recurrence-free survival. And an experienced neurosurgeon is one who has seen enough complications that he or she has a vague idea of how to avoid them, and this will come down to technique and experience. Harvey Cushing, I think, nearly 100 years ago, encapsulated the problem that we face by describing these as the kaleidoscopic tumors, solid and cystic, whose management is one of the most baffling problems to the neurosurgeon. This was true in the 1920s, and it is true in the 2020s. And for over 50 years, the optimal treatment, particularly in pediatric craniopharyngiomas, has been controversial. At the bottom, you see two of the luminaries of the 50s, 60s, and 70s in the controversy. On the left, John Shillito, on the right, Bill Sweet, both from Boston, one advocating conservative therapy with radiation, the other advocating radical resection. Bill Sweet was the one who first noted the glial tumor interface in the hypothalamus between a craniopharyngioma and the surrounding normal tissue. I think as we look at craniopharyngioma today and look at the literature, I think many institutions worldwide have demonstrated that both total resection and partial resection with irradiation will give us similar 10-year progression-free and overall survival, which is, I think, quite impressive. Of course, 10 years is but a drop in the proverbial bucket for a child. We really need to see the 20, 30, and 40-year outcomes, some of which I hope to share with you today based upon my 36-year experience. And even today, in 2021, we continue to have limited information on the long-term quality of life in adult survivors of childhood craniopharyngioma. So I've always approached craniopharyngioma with 4 philosophic assumptions. One, we should treat pediatric craniopharyngiomas with curative intent whenever possible. Obviously, there may be socioeconomic, geographic, or patient factors that limit this, but I think as pediatric neurosurgeons, our goal is to cure. After all, although in my 60s, I would be delighted with 2 or 3 years of palliation if my craniopharyngioma needed treatment, I'm not sure a family of a 4-year-old or 7-year-old child would feel the same way. They're not looking at 3, 4, 5-year outcomes, they're looking at 70-year outcomes. I think the best chance of cure is at the time of the first treatment. And I believe that all children, regardless of institution, regardless of your philosophic prejudice, deserve pre-treatment consultations with both neurosurgery and radiation oncology so that a family has the full understanding of the spectrum of treatments and the spectrum of long-term complications. If one looks towards radical surgery, which we'll use as a synonym for gross total resection, there is no question you need a degree of socioeconomic support, particularly for the postoperative management of endocrine deficiencies. Radical resection, I believe, does provide good quality of life, and I hope to be showing you 20+ year data that will allow you to come to this conclusion as well. And I will also like to share with you some information and data about the role of experience. As we look at measures of outcome, they've evolved over my professional lifetime. I entered medical school in 1974, and I still engage in active practice today, nearly 45 years later. Before the 1970s, the concern in treatment was always mortality and morbidity. In the 1980s, we started to look at gross measures of outcome, and we adopted the head trauma scale, the Glasgow outcome scale, which is a 5-tiered, very gross measurement of functional outcome. The 1990s showed the introduction, first in oncology and then in other fields of neurosurgery, of the Karnofsky scale for adults and the Lansky scale for children. Over the last 20 years, we've definitely been looking at more detailed quality of life measures. These include detailed neurocognitive measures, neuroendocrine evaluation, formal ophthalmologic examination, and most important, the impact of hypothalamic injury. Having said all this, after over 20 years of dedicated research and interest in long-term quality of life, there does not remain a gold standard. There are many quality of life indices, and we have not yet come to a single agreement on what is best. We tried to look at this, and we devised a craniopharyngioma clinical status score that we could use for both pre and postoperative outcomes and published this about a decade ago. Some of this is a takeoff on other work, particularly the work of DeVille and colleagues from Great Ormond Street. But it looks at 5 domains, which I think encompass the spectrum of benefits and complications with craniopharyngioma. That is neurologic deficits, visual outcomes, pituitary function, hypothalamic function as distinct from pituitary function, and educational outcome. After all, when we look at children, education may be the best indicator of how well we do. Because if we impair a child's ability to advance educationally, we condemn them to limited social mobility and limited social interaction. So first and foremost, can we say, is there a gold standard that we should all achieve when treating craniopharyngioma, no matter what philosophy or technical standard that we hold? And I think probably the best information we have on long-term outcome comes from Hermann Mueller and his nearly 3-decade-long craniopharyngioma study in Germany. What they've done is, for nearly 30 years, captured almost all of the pediatric craniopharyngiomas in all the centers in Germany, and they've been able to get long-term endocrine and clinical outcome, as well as progression-free and overall survival. There is a problem with the data, though. Although it is encompassing and it is very population-based, because it is so many institutions, you don't necessarily gain any one institution with true technical excellence or a center of excellence. And in fact, when you look at their definition of center size on the far left of the screen, you can see large size would be greater than 5 patients in 6 years. That is less than 1 patient a year treated. And small size would be 1 patient in 6 years. In their initial study and then their subsequent studies, which is just shy of 50 centers, you can see that large centers, again, barely seeing 1 patient a year, only occupy about 15% of the overall group. And in fact, there's a slightly inverse relationship between experience and the likelihood of radical surgery. That is, the more inexperienced, the less high volume centers tended to do slightly more radical surgery. So again, over 90% of these centers are seeing less than 1 patient a year, and most less than 2 patients in 5 years. So again, it is prospective, it's multi-institutional. Within each center, there is some uniform treatment, but there is no overall uniform strategy. And low volume centers, low experience centers, tended to perform more gross total resection. When you look at the 20-year and 30-year outcome, both for those treated with complete resection, CR, and incomplete with radiation, IR, you see very similar 20 and now 30-year progression-free and overall survival, with overall survival at 20 years being somewhere just north of 75%, and progression-free survival being about 65%. Is this a gold standard? I think this is a gold standard for community practice. That is, this is not a standard that centers of excellence and high volume centers should hold themselves to. But again, if you're looking across the board and perhaps across nations, whether they are high income, middle income, or low income, this would be the minimum standard of outcome that one could expect in treating craniopharyngioma. And if a center could not achieve this, they probably should not be treating these patients. The flip to what's a standard is, can we differentiate those high risk from lower risk patients, theoretically ones who are better suited for radical resection, perhaps ones that are better suited for incomplete resection and radiation to maximize quality of life and overall survival. And I think we owe a great debt to the group at NECA Enfants Malades in Paris, and particularly Stephanie Puget. Professor Puget looked at their series of well over 150 tumors, and did both a retrospective and prospective confirmation protocol. They divided their tumors into 3 classifications based on both pre and postoperative imaging. Preoperative imaging and postoperative imaging were classified on a 0 to 2 scale, basically looking at hypothalamic involvement. A 0 would be your classic prechiasmatic tumor, where the tumor really doesn't go posterior to the optic chiasm. It can be intracellular, which is typical, or can go pre-chiasmatic. The class 1 are those that will be involving the postchiasmatic region. I'm sorry about that. Postchiasmatic region, but are not extending all the way back to the mammillary bodies, as we see here, where the entire floor of the third ventricle right up to the mammillary body is involved in the grade 2 tumors. And then post-operatively, you see the same thing. Grade 0, you see no defect in the floor of the third ventricle. Grade 1, you see a small defect, and here you see a complete defect. And what they demonstrated is that those that were grade 2 had a much higher risk of long-term hypothalamic injury. So based on their retrospective data, they engaged in a prospective study, which was approximately half of the patients they reported. And basically, grade 0 would go for complete resection whenever possible. Grade 1, complete if feasible. But grade 2 would be an intended subtotal resection with leaving tumor in the hypothalamus, and then, depending upon age, either radiating or not radiating. When they looked at their outcomes with the HSS, meaning hypothalamic sparing surgery, or the second cohort, what you can see is that the number of children who had significant grade 2 obesity, morbid obesity, was basically cut in half by their hypothalamic sparing surgery. That is, it went from 54% of those with grade 2 having morbid obesity to 28% having it. But please notice, even in their grade 1 patients, they still had nearly 10% who were overweight, or actually grade 0, and grade 1 obesity about 23%. So again, only about 40%, that's 60% of all their patients, even with hypothalamic sparing surgery, had some degree of obesity, although it was about 28% with the hypothalamic sparing surgery. Remember this figure of 28%, we'll come back to it later. So what are the treatment options? Again, I think we have radical surgery, radiation alone, radiation plus partial resection, radiation plus cyst aspiration, intracystic therapies, both P32, bleomycin, and interferon. I think these are all potentially curative therapies and are appropriate in the pediatric age range. I personally do not believe that partial resection alone or cyst aspiration alone is an adequate treatment other than to temporize to get a child to a center where one of the more definitive therapies can be offered. We've taken an attitude over the last 35, 36 years of total resection of primary tumors. That continues to be my general philosophy to this date, and has been in the craniopharyngiomas I've resected over the past 2 years. So we're going to go in with an attitude that we will try to obtain a total resection. If we do obtain a total resection and there is recurrence, we will again do surgery in the hopes of again getting total resection. If we are able to achieve a GTR on the second go around, we'll again observe. But if there is tumor adherent to the adventitia vessels firmly embedded in the hypothalamus, then after a first recurrence with an attempt at salvage surgery, we'll go to radiation therapy. Second recurrence after gross total resection, definitely radiation. Now again, we're talking pediatrics. This is not a panacea for all age groups. My adult colleagues often ask me to help them with their adult craniopharyngiomas. So this is a typical case of one that's very well managed endoscopically transventricular, an 80-year-old with memory deficits who had a transventricular endoscopic fenestration partial resection, recurred a couple of years later, had another one, and then ultimately had focused radiation, and she actually survived 10 years without any significant new problems, with improvement in many memory deficits and maintaining a normal endocrine function. But again, this is an elderly individual. Even more elderly was a 90-year-old with multiple comorbidities, but really presenting at this point with cognitive difficulty. Here her tumor is far more solid and somewhat atypical for adult tumors, somewhat calcified. And here's one where basically a shunt was all we did. And we ended up palliating this patient and improving her cognitive function for the remaining 5 years of her life. Coming back to pediatrics, I would like to also address during this talk several things that I consider conventional wisdom. Younger children have worse outcomes. Giant tumors are more difficult and more likely to recur. Any amount of calcification increases the risk of recurrence and deserves adjuvant therapy. And hypothalamic dysfunction, obesity is inevitable and will always lead to poor quality of life. So this is the conventional wisdom that I think is still promulgated by the majority of people out there. And I'd like to address these throughout the remainder of the talk over the next 30 minutes or so. So today's questions are: what's the likelihood of recurrence and cure? What's the impact of those factors of age, size, and calcification? Acute and late morbidity and mortality, quality of life, which will take about a quarter of this talk, and who should treat? Does experience matter? I truncated this series 6 years ago that we have a minimum of 5 years of follow-up in all these patients. We'll be dealing with about 110 pediatric patients. 2/3 were treated primarily by me, and about 1/3 came to me after being treated elsewhere with recurrent disease. Our mean follow-up is 19 years with a minimum of 6 and a maximum of 36. As one would expect, primary tumors were younger than recurrent tumors, which also demonstrates the general pattern. If one is going to recur after primary treatment, the majority of recurrences will be within the first 5 years. The other thing that I think is different in pediatric versus the adult population is the tumors tend to be larger. Children can adapt to the growing tumor due to the compliance of the brain. Visual deficits, which were often the first hallmark, or diminished sexual function, another hallmark, are relatively under-recognized in pediatrics. It is not atypical to hear a story of a child over a year or two gradually getting closer and closer to the television set in order to watch their favorite cartoon show, which was indeed an indicator of progressive disease and increasing visual deficit. At least half and often 2/3 of these tumors throughout the world will be large or giant-sized tumors compared to the adult population, where 2/3 tend to be small to medium. And about 1/3 will have hydrocephalus, another indication of the large size. Looking at whether they're pre or post-chiasmatic, leaving out the Puget classification for the time being, not the vast majority, but roughly half of them are pre-chiasmatic, a relatively small number in childhood will be purely intracellular, and at least 10 to 15% will be complex. And in our experience, an extended pterional approach was used in over 95% of these surgeries. We had 8 stage surgeries, 2 in primary and 6 recurrent tumors, where we first did a pterional approach and followed up in 7 cases with a transnasal endoscopic approach, and in 1 case with a transventricular approach. So let me talk a little bit about surgical technique. How can I be a surgeon and not at least give my prejudice on technique? And let's briefly talk about fixation, positioning, incision, craniotomy, and dissection. For cranial fixation, I like the Sagita headrest. It gives us multiple degrees of freedom and allows pins to be used in as young as 18 months old. The rotational freedom that you can achieve, I think, is quite impressive. And you can see that with this, you get almost 60 degrees of approach, going from almost a classic subfrontal to a nearly subtemporal approach. For positioning, I always talk about rotating, flexing, and extending. You want to rotate the head to the contralateral side, extend the head inferiorly, so you get a nice flat approach to the skull base, and then flex the head slightly forward. In terms of the incision, the classic is the curvilinear incision behind the hairline. I've adopted from our plastic surgery colleagues the stealth incision. That is the zigzag incision, which has the tremendous advantage of not leaving a permanent part in the hair. In almost all females and most men who will wear their hair longer than about ½ an inch, the scar essentially becomes invisible. And unlike adults, where we tend to reflect the muscle separate from the scalp flap to get low to the skull base, in children, the muscle is relatively thin and can easily be reflected with the scalp, which avoids injury to the frontalis branch of the facial nerve, as well as, I believe, gives us less atrophy of the muscle and less retraction. I always dissect out the periorbita, and in children, we can achieve a fronto-orbitozygomatic craniotomy as a one-piece construct. That is, we take off the roof of the orbit and the zygomatic process together with the frontal and temporal bones. Usually we will place 2 burr holes, one down in the lobe temporal region, one in the keyhole, and then we'll work our craniotome along the posterior and anterior aspect, divide the supraorbital rim medially, divide the rim at the level of the zygomatic process of the frontal bone, and then come across the roof of the orbit. And in children, we can often use curved osteotomes to achieve this. In terms of microdissection, regardless of whether they're pre or retrochiasmatic, we always want to do a wide Sylvian fissure dissection. This allows drainage of CSF and almost always obviates the need for putting a ventricular drain or a lumbar catheter to get relaxation. I also commonly use mannitol for relaxation. The other thing I like is, as I dissect the Sylvian fissure, any minor tremor that I have resolves as I get used to the microdissection. We always identify the vascular anatomy distally, looking at the distal branch of the middle cerebral artery, follow it to the main middle cerebral artery trunk, follow that back to carotid bifurcation, and then to the internal carotid, identifying the anterior cerebral as well. Whenever dealing with suprasellar pathology, the vessels tend to be the constant, and the tumor tends to distort and displace the optic apparatus. So we then identify the optic apparatus, and then we do our arachnoid dissection. I tend to keep the tumor and the cysts relatively full as long as I can because it maintains the arachnoidal plane. If you prematurely decompress the cyst or completely decompress the cyst, the thin, almost diaphanous walls of a craniopharyngioma may collapse on itself and sort of interdigitate with the overlying arachnoid and prevent you from getting a true gross total resection. And then finally, internal tumor decompression and removal of the capsule. I'm going to show a couple of quick videos just to give examples of both a pre and retrochiasmatic approach. This was a 12-year-old with a 3-centimeter pre-chiasmatic tumor, a Puget grade 0. Hopefully this will play. So here we've gone down to the optic nerve on the right side. We can see beginnings of the carotid over here. And the initial approach is to work across to the contralateral side to see the left optic nerve, always maintaining that arachnoidal plane, pulling tumor away from normal structures. Then we work the same way on the ipsilateral side. In the optic carotid triangle is a very good avenue, and generally working gradually, creating that arachnoidal plane. Craniopharyngiomas are initially extra-arachnoidal, and they usually have a double layer of arachnoid between themselves and the overlying neural structures. Once we've been able to get around particularly the optic nerves and free a prechiasmatic tumor from the nerve, we tend to start to work around the back. We want to be sure that we can see down to the membrane of Liliequist. That way we know our basilar artery, the basilar bifurcation, the perforators are free. It is rare for primary craniopharyngioma to violate the membrane of Liliequist. Working across the other side to see the contralateral carotid. And now that we've done the maximal arachnoidal dissection, we can start decompressing the cyst, which will give us a lot more room. Here we can see the cyst collapsing. And we'll see the typical contents of the cyst fluid. That's sort of creamy, often called crankcase oil fluid. We can now see the contralateral optic nerve better, and we can preserve the small perforating branches going to the optic chiasm and hypothalamus. Control. Again, we've not completely decompressed the tumor, allowing us to maintain those planes and doing more arachnoidal dissection. And now that we have, as we suction out the content of the cyst, we can see that we've achieved about 90% of our dissection. Here we see the pituitary stalk in the distance, and we note that the tumor is not separating from the stalk. And so we will coagulate and cut the stalk. And I try to cut it as distant to the hypothalamus as possible. If I know early on the stalk is involved, I will cut it early to prevent retraction on the hypothalamus. And then we work intracellular, creating planes. I find little pledgets of oxycell or surgicell gauze are terrific for controlling the oozing from the cavernous sinus. Flow Seal, if you have access to that, is another excellent agent, or Surgiflow, I guess is another brand name. And we can work all the way around the tumor, preserving the normal pituitary in the distance, and ultimately obtaining our total resection. We have about 15 more seconds. And here's our final view where we can see both carotids, both optic nerves, the optic chiasm. We can see the clean floor of the sella turcica, and either a micro mirror or an angled endoscope is used to ensure that you have not left tumor under the anterior lip beneath the tuberculum sellae. And again, this another case, 8-month-old boy, that was his tumor at surgery. That's him 12 years later. He's now 30 years out from surgery. His greatest problem is he's become a video gaming addict and programmer. And his mother blames his interest in video games on his surgery at 8 months of age. Another girl, grade 1 tumor. By the way, I always get CT scans on these patients because I think the CT still is the superior test to show a calcification, which will be an area of difficulty with dissection. Again, typical appearance, pre, post. She's now 25 years post-operative and she has 5 children. This was a 3-year-old doctor's son presented with this large grade 2 craniopharyngioma. And let's just look at a quick surgical video there to see some of the difference in technique. So here we are starting with the arachnoid dissection, starting a little earlier in the operation, opening the arachnoid fairly far lateral. You can see my little tremor there. But again, open the arachnoid, draining CSF, getting relaxation, seeing the distal branches of the middle cerebral there, working our way deep, identifying the main middle cerebral artery trunk, going down to carotid, down to the bifurcation, seeing the optic nerve medial to carotid. Again, this is without these retractors are merely placeholders. They're really not retracting the brain significantly. And you can see the tremendous relaxation you get with just with CSF drainage. You can see the third nerve laterally underneath my suction. And so we're now separating out in every plane possible. Definitely work in the above the carotid bifurcation, dissecting the perforators free, working medial to carotid, going down again. There we can see the posterior cerebral in the distance coming off the basilar, seeing an intact liliquist, which is very reassuring. Again, gradually pushing the tumor away from the vessels, maintaining the arachnoidal plane, dissecting out posterior communicator, anterior carotidal, preserving all the perforators. Now, the chiasm, if you remember, is relatively anteriorly displaced, the so-called prefixed chiasm. It's really not prefixed, it's really displaced anteriorly by the postchiasmatic tumor. Eventually, you will have to work through lamina terminalis. You can see these little vessels that run right down the middle of the optic chiasm, which is a good way of maintaining your orientation on midline. Again, we want to gently dissect. We don't want to just pull the tumor. We want to put a little traction, move normal tissue away, take out calcifications, and continue to work. Here we see the distal stalk that's involved, and we're dividing it to allow us to dissect easier. Working under the optic tracts, seeing more of the carotid bifurcation. Again, working in the carotid bifurcation, maintaining the perforators, both from the bifurcation, perforators going off of the anterior cerebral. If you see the recurrent artery, you want to preserve that as well. Everything needs to be preserved. You'll often see a little bit of spasm of the vessels, as you can see there. Cool irrigation and pledgets of gel foam soaked in papaverine are very good for reversing spasm. Again, we're pushing normal tissue away. There is a definite plane, but you don't want to tug on that plane and pull normal tissue with you. And again, through the lamina terminalis, beneath the chiasm, go back and forth, maintain your planes. Whenever you would hit a roadblock where it's not coming, again, go to the other area and try to put traction there. Here we have one of those little pledgets of gel foam soaked in papaverine to help with the spasm. Getting our last small pieces of the tumor out. And there's the final image where you can see all the way out here, we've preserved posterior communicator, anterior carotidal, all the perforators, middle cerebral perforators, anterior cerebral perforators, right nerve, left nerve, chiasm, both optic tracts, looking to the third ventricle. And this is what this boy looks like 12 years later, doing very well, excellent in school, and now has his black belt in karate. About a third of the patients have been recurrent tumors. Roughly half of the recurrent tumors that I've done have been patients of mine who have recurred and had second surgeries. And you can see there's a vast array of different therapies that have been used prior to me seeing the other patients. Multiple Ommaya aspirations, which I think is a disaster, partial resection, partial plus radiation, partial resection plus Ommayas. This is one of my patients. I call it a secondary tumor that is I resected. There we go. Large craniopharyngioma. Initially post-op looked great. 6 months post-op, I said, oh, that's just a dependable cyst from scarring. Going back to be an optimist, sometimes a little bit too optimistic. But in fact, at 12 months, it enlarged and we went transventricular, removed that. And this girl is now free of disease and actually works as a fashion model nearly 30 years later. This is what I think is the disaster of multiple aspirations. This was a 3-year-old girl from Brazil where the goal was to preserve endocrine function. But each time that an Ommaya was placed and it aspirated, it would collapse down, the vision would never fully recover, and you had this stepwise decline in visual function, as well as with each aspiration and the walls coapting, you got more and more calcification. So ultimately you were left with a hard calcified lesion being over 50% of the mass, rather than the initial almost purely cystic lesion, which is an easier surgical target. And in fact, this is what it looks like at surgery, where the junction of the optic nerve and the chiasm on the left side was basically translucent. She was functionally blind pre-op, she was functionally blind post-op, and 25 years later, she remains unchanged, although cognitively normal, not obese, but blind, which particularly in Brazilian society is a tremendous social morbidity. So I think multiple aspirations as primary treatment is not the way to go, if at all possible, to get more definitive therapy. This is what we all fear. An 11-year-old girl with a near total resection elsewhere twice had a stroke on the second go around. And then we were able to get this as a total resection, first from a terional approach and then a second transventricular approach. And she's remained disease-free for 2 decades. And this is the ultimate disaster: partial resection, irradiation, multiple cyst aspirations, bleomycin, and she ultimately had an ossified rock at the base of her skull. And we attempted resection, but she ultimately did not do well and succumbed to her disease. So what are the outcomes from this series? So let's try to address those questions. What is the likelihood of surgical cure? With our primary patients, we have had a 82% 20-year progression-free survival. Those tumors that we have tried to retrieve after having been operated on elsewhere, we have only a 45% 20-year progression-free survival. So there's no question, as I said earlier, your first go-round is your best chance for curative therapy. And in fact, when we look at the ability to achieve durable remission, it is almost 98% in those who have had a primary surgery, secondary surgery, and tertiary adjuvant radiation therapy, whereas at least 25% of the patients who come to us with previous treatments elsewhere have had progressive or active disease. Now, we have to be a little careful about what is true progression. These are 3 patients, all of whom developed little cystic lesions 6 to 12 years following surgery. And in 2 of those little cystic lesions either stabilized or spontaneously regressed, and 1 enlarged. So this one, I believe, is a true tumor. These others, I'm not so sure. And this young girl was retrieved with Gamma knife, and she's actually now a physician. On the other hand, this also shows the need for constant surveillance. This was a young girl who 4 years post-op had a fusiform dilatation of the carotid, but this was all stable. 5 years post-op, she was about to start growth hormone therapy, and there was a question of a small amount of residual or recurrent disease. We recommended a MRI 3 months after starting growth hormone. For a variety of social reasons, this was not obtained. And 8 months between here and here, she had this multicystic recurrent tumor, and she has subsequently had multiple recurrences. I know there is no data that says growth hormone causes these to recur. Nonetheless, I believe while children are on growth hormone therapy, you do need to be vigilant. And at least for the first year, I would get scans at 4-month intervals. Impact of age, tumor size, and residual calcifications. Age alone, whether you're under 6 or over 6, had no difference on long-term progression-free survival. If anything, the younger children did slightly better. Giant craniopharyngiomas, Again, for primary tumors, they did as well as any other group, although giant recurrent tumors were definitely a disaster. And when you look at overall survival, there really was no statistical difference in outcome. Minimal calcifications does not portend recurrence. This was something that Harold Hoffman pointed out in the 1980s, and we did a study 20 years later, which basically confirmed it. So you do not need to radiate a child who has minimal calcifications without any enhancing disease. Acute and late morbidity and mortality. Well, again, looking at overall survival, if you have a virgin tumor, the likelihood of being alive 20 years out is almost 90%. Again, in our experience, this is significantly better than what we saw in the German craniopharyngioma series. And I think it reflects the fact that this is a high volume center. By the way, this is not high volume as in some areas of the world, which literally do 100 or more craniopharyngiomas a year. I think throughout the Western Hemisphere, high volume centers defined as 2 to 5 tumors a year. And that's pretty much what we've seen over the last 25, 30 years. Recurrent tumors actually do follow that exact same survival curve as we saw with the craniopharyngioma group. What was the cause of our mortality? We had 2 perioperative deaths. One was a 15-year-old with a 2-centimeter prechiasmatic tumor who had vasospasm on post-op day 2. We initiated nimodipine in all these patients, and since 1991, we have not had any subsequent strokes. And we had a 7-year-old who had familial dysautonomia and autism, and actually did well for 4 days and then developed a dysautonomic crisis and died. Late mortality, we had one child, a 15-year-old, who had a severe intraoperative hemorrhage, was disabled, and died 3 years later from pneumonia. At least 3 patients who we believe had Addisonian crises that were not treated, including a 33-year-old who was over 20 years post-op working full-time, who went to a so-called bachelor's party in Las Vegas, did not take his steroids, got very inebriated and had an Addisonian crisis. And we've had one patient who died from hepatic failure due to morbid obesity. On the other hand, those children we tried to retrieve after primary recurrence elsewhere had a 22% case mortality, although our operative mortality was only about 2%, similar to the primary tumors. And we've had 2 patients who've had radiation-induced glioblastomas. This was an Israeli girl who came to us after several aspirations. We obtained a gross total resection. This was early in my experience, and she did have some residual calcifications near the anterior communicator that I saw at surgery and we saw post-op. This is not someone that I would radiate at this time, but back then we did give radiation, and 7 years later, as she was about to enter the university, she developed a glioblastoma and died. This was another girl from, referred to us from another major center, having had 3 surgeries over 12 years and radiation, which was 4, with this multiply recurrent tumor. We achieved a gross total resection with reasonable outcome for quality of life, was no different than preoperatively. But notice she has these flare changes. This was the post-op contrast and flare image. We didn't think much of it at the time, and that was a mistake, because 6 months later, she developed this diffuse intrinsic pontine glioma, obviously a late sequelae of her radiation. When we look at a multivariate analysis, there's no question that subtotal resection and radiation had a worse outcome in our series, and granted it is a prejudicial series, both in overall and progression-free survival. Hydrocephalus and a shunt, which went along with large tumors, tended to portend a worse outcome as well. In terms of overall neurologic deficits, using our scale that we talked about early in this lecture, there were deficits pre-op, there were deficits post-op, but the net change, that is new strokes, were a definite minority, less than 5%. Looking at hypothalamic dysfunction, taking off from DeVille and colleagues, we had about 20% of our patients had preoperative hypothalamic dysfunction, and post-op, what we can see is there was a net increase in hypothalamic dysfunction, but a minority, only about 5%, had severe dysfunction. Looking at body mass and obesity, in our series, 16% had morbid obesity. So 16% with a non-hypothalamic sparing strategy had morbid obesity, and we could not see any real difference between primary or secondary tumors, although primary tended to trend better. And in fact, younger children did better than older children. They did gain weight, but few were morbidly obese. On the other hand, recurrent tumors, 30% of them had severe obesity. Many of them came to us obese, and many of them had retrochiasmatic tumors. And now for the last 10 minutes, let's talk about quality of life. Well, let's look at education. How were they doing pre-op? How were they doing post-op? You can see that pre-op, over half the patients were not normal, that they were requiring some degree of assistance, both primary and recurrent tumors. When we look at the net change in educational status, a small number got better. Many of them achieved normal status, and only about 10% had significant cognitive impairment in education that required special schooling. Looking at IQ, there was a trend for larger tumors to have slightly lower IQ, particularly performance IQ more than verbal. And location, retrochiasmatic tumors did have, again, more deficit in terms of performance IQ. Hydrocephalus that resolved without shunting did not make a difference, though those who had significant hydrocephalus also had significant impairments, full-scale verbal and performance IQ. We used the two quality of life measures, the Child Health Questionnaire, the Achabach Behavior Checklist. These are Likert scales. So basically 50 is the mean, 10 in either direction is the normal range, so 40 to 60 is normal. More than 10 in either direction puts you at risk of clinical symptomatology. So you can see that when we look at the overall behavioral checklists, the one area where children tended to be at risk was in activities and in internalizing behaviors, but the rest was truly within a normal range and actually sort of resembles the pattern you see in many chronic diseases: juvenile rheumatoid arthritis, juvenile diabetes, juvenile kidney disease. Looking at location, there was definitely a trend for behavioral issues in the retrochiasmatic, hypothalamically involving tumors, particularly school performance, total behaviors, and the internalizing, externalizing behaviors. Recurrence, interestingly, in and of itself did not make a difference, although there was a trend with activities to be somewhat worse. Looking at the overall quality of life, there was definitely an impact on overall physical quality of life in those who had recurrence, and a general increase in physical problems, though not very significant, throughout. So the last thing I want to do is really look at the long term. We're able to get a group of patients who are at least 2 decades after total resection of craniopharyngioma, all of whom have been my patients. So we have some consistency in treatment. When we look at this group of patients, all of them at least completed secondary school, and roughly 50% of them had college or advanced degrees, including 2 who went on to be physicians. Only 2 were unemployed. The rest were either employed or were still in school. And interesting, in spite of visual deficits, 75% of these patients were able to drive. Marital status was different than their peers. More of them were single, and more of them were still living at home, although currently in the United States, roughly 1/3 of university graduates spend up to 5 years living with their parents. Among the 20 who answered the full questionnaire, only 1 had a child, but among the 45 who answered part of our questionnaire, we had 7 patients who had children, 5 of whom were women. We want to look at the overall SF-36, a global look at quality of life, because it has good age normative data. And when we looked at both cognitive and physical performance and compared these patients with their normal peers, we could not see any significant difference in the SF-36. When we looked at the long-term BMI, we once again saw that if we look at patients in the United States, and general population of the United States, which is an obese population, versus our patients, we see fewer of them are completely normal, a significant number are overweight or mildly obese, but only 8% were classified as morbidly obese, which again, so we have about a 75%, 80% incidence of obesity, which is higher than what we see with the hypothalamic sparing surgery, but the morbid obesity remains low. We did see, as Mueller and his colleagues have pointed out, that the likelihood of obesity increases over time. And it definitely correlated not to prechiasmatic, retrochiasmatic, or complex, but rather to whether or not the hypothalamic involvement was present. Again, showing the tremendous value of the Puget scale. Interestingly, we thought obesity would adversely impact quality of life. And in fact, there was no correlation between obesity and quality of life. This is very different than what Harold Hoffman wrote about back in 1986. I don't know if it's because this is longer follow-up, if we have an obese population in general in the United States, but interestingly, these patients have done well. They interestingly also all have similar sexual interest and sexual activity and ability to become sexually aroused to their normal age match peers. And does finally experience matter in our last 2 minutes? Well, again, looking at our craniopharyngioma outcome scale, looking at the variables of age, giant tumor, recurrent tumor, hydrocephalus, retrochiasmatic, the pre-op scale, surgeon experience, what we see is definitely the preoperative status made a strong impact on how they did long-term, which goes along, I think, a lot with the 1/3 of our patients who were recurrent disease patients that had more deficits coming into surgery. And the surgeon's experience was significant in terms of deficit, hypothalamic function, and education. And here we have my own experience looking in a 5-year quintiles, and you can see that with each 5-year period, the improvement in the outcomes for each level of function in terms of neurologic deficits coming almost to 0, improvement in hypothalamic, and improvement in educational status. I think this isn't unexpected, since we do expect these patients to have full anterior pituitary dysfunction, because we are taking the stalk in the majority. Visual deficits are often dictated by how they come to us. And that should be the end. And so in conclusion, 90% of primary craniopharyngiomas can be cured with surgery alone with good quality of life, but you do need that safety net. You do need socioeconomic resources. Disease control can be obtained in 95% of patients with primary surgery, secondary surgery, and tertiary radiation. Mortality should be under 2%, and we need to get our case mortality long-term outcome down to 4 to 5%. The future, better identification of children at risk for hypothalamic injury. After all, whether it's our series or the Puget series, at least 60 to 80% of grade 2 tumors do not have severe hypothalamic injury after gross total resection. There are medical treatments for obesity, which I think on the horizon may significantly improve our ability to treat. 10 and 20-year survival and quality of life comparisons are needed between the various modalities. And I think the future will be molecular targets. We've seen that in adult craniopharyngiomas and the papillary craniopharyngiomas, where there has been a proof of concept that BRAF inhibitors will reduce the size of those tumors. We have recently published one patient who's responded to a MEK inhibitor, but that's just one patient. But I think it's just the crack in the door to a bright future of additional multimodality therapy. Thank you very much for your attention.
Thank you very much, Dr. Wisoff. If there was a master class in pediatric neurosurgery, this was it was an elegant lecture of an impressive experience and very scientific and scholarly lecture. I'm glad that we have recorded it as well. First of all, I will field a few of the questions that are on the chat box, and then I'll invite a few of our participants to ask questions. We have got a few senior colleagues there, and also anyone who wants to ask questions, please put your name on the chat box. I will pull you up or put your questions. So I think in terms of the one of the questions from Dr. Dunia, in terms of predicting a VP shunt pre-op, what factors can predict the need for VP shunt pre or post-op? Thanks, Dr. Wisoff.
Sure. I don't think we've looked at that specifically. My experience has been that the majority of tumors that you are able to at least decompress the third ventricle will spontaneously achieve normal CSF circulation, and shunts can be avoided. I strongly believe that one should not put in a preoperative shunt except in the most dire of circumstances, or if you're going to need to transfer the patient to another institution and you need to stabilize. Definitely in the short run, if a patient comes to you, you need to do the endocrine evaluation, you need to make sure they're stable, and that will take a bit of time. But many of these patients can be stabilized on steroids. So I would try to avoid a shunt when possible.
Thank you. We have a question from Dr. Ved Prakash Maurya. I'll get him to ask the question. Dr. Maurya, do you want to mention where you are calling from, and could you please ask Dr. Wisoff your question? Thank you.
Thank you very much, sir. It was a very wonderful presentation, sir. I really learned a lot. I am asking this question from Lucknow, India, the capital city of northern part of the state. So my question is, sir, we have recently operated a child, 2-year-old. By the time he presented to our institute, he was totally blind. The perception of light was totally absent. And his hormonal profiles were a bit in the normal range. So we attempted surgery. We entered with the intention to be conservative. But by the time we are resecting it, we thought that the child is already bilateral blind. What we are giving, he will end up with radiotherapy recurrence. So we attempted a gross total resection. In that attempt, we have damaged the hypothalamic and pituitary stalk, we suppose, and we had a bad outcome. So I just want to know from you, what's your take for this? Because it's a very confusing situation. 2 years old, bilateral blind, perception of light is absent. What should be the management guideline?
It's an interesting question. Again, I think visual function is definitely something we try to preserve, but we're also trying to play the long game, if you will. That is, what is going to happen over the next 20 years?
Sure.
I think radiation therapy and partial resection is definitely a possibility. Again, did the tumor go primarily retrochiasmatic? Was it significantly involving the hypothalamus? If that's the case, then I think there's definitely going to be more of an argument to move towards partial resection, decompression, and radiation. If you can reduce the volume, you can limit the field of radiation, which obviously in a 2-year-old would be beneficial. Another option would be intracystic therapy if it was a large cystic tumor. I wish I could say there was a right or wrong. I think each case does need to be approached on its own merits, and each center has to also decide what is the ability to manage the complications. There's no question. I'm very fortunate that I have a team of 4, now 6 endocrinologists who I work with, who are wizards at managing pituitary and hypothalamic dysfunction. So as long as we don't develop morbid obesity, almost everything can be managed. But it is very intensive. It's very costly. It's long-term commitment. It's families having access. So there are multiple factors there beyond the excellence and capabilities of the surgeon.
Thank you very much, sir. Thank you.
Thank you. Thank you very much, Doctor. I'm going to move to a question from myself while we are fielding further questions. Dr. Wisoff, you mentioned and you reiterated just now in terms of how well a setup is there to deal with post-op complications. And, we surgeons are very optimistic people sometimes, and patients are keen to have you to operate. And, in terms of, and, even in many developed countries, managing the post-op endocrine problems after craniopharyngioma is very, very challenging. Do you have any thoughts on when a department in a developing country or even semi-developed country should do, and when it's better just to have radiotherapy or palliation? Thanks.
Sure. First, I believe that every patient needs to hear from the radiation oncologist. And we've created this system where I will not operate on a patient until they've seen the radiation oncologist and gotten their perspective. Because I think, Naren, you're absolutely right. We tend to be enthusiastic. It's very hard not to be an enthusiastic surgeon and do well. And that enthusiasm can be infectious in a bad way. The families who feel they've just walked through a minefield with this diagnosis are hanging on our every word, and it's very easy for us to sway them to one therapy or another. So I do try to do my best to point out the adverse impact of surgery and to let them hear from a non-surgeon. If I was to give broad advice, to a center, I would definitely say that the tumors that I think deserve upfront surgical management are those that are intracellular. I would say that those that are completely prechiasmatic, the grade 0 Puget scale. Those I would say should be the cases that will do best surgically, provided that the center and the team is experienced in working in the suprasellar region in children. These are also the cases that have the best outcomes with a transnasal endoscopic approach. And I think, transnasal endoscopic is a wonderful approach, provided you have the experience and expertise. I think that the Puget 1, the ones that extend retrochiasmatic but do not completely fill the third and do not completely penetrate the floor of the third ventricle, are the tumors that should be done in centers with experience. And I think that even in these experience centers, they have to know the limits of their medical system. And if there is tumor adherent to the hypothalamus, to leave that behind and consider postoperative irradiation. I think the Puget 2 tumors are the ones that are going to be best managed by few reference centers. Again, this is not possible throughout the world, but if there is going to be aggressive surgery, by the way, at Necker, they are aggressive with the grade 2 tumors, they just simply don't remove the last 10% of the disease. If the center is experienced, then they should try to go for an 80–90% resection to reduce the radiation field. If a center is not experienced, then those are the centers that upfront should decompress cysts when possible and very early on use radiation therapy. So I would say that looking worldwide, I would say probably it's about 25% of craniopharyngiomas that should be surgically resected almost in anyone's hands. About 45% that should be resected or have consideration of resection in experienced hands. And about 30% that should either have hypothalamic sparing surgery, or if the family does desire an attempt at total resection, should be sent to a reference center.
Thank you. Thank you very much, Dr. Wisoff. There's a question from Dr. Bhagat Singh from Tamil Nadu, India. His question is, first of all, great presentation.
Naren, you just froze. Hello? Hello?
Hello, sir.
Hi, are you there?
Yeah, I am. No, his connection is, I think there is some problem. Can I read the question for you, sir?
Absolutely, thank you.
Yeah, he congratulated you for your great presentation, Dr. Bhagat Singh. He is asking that what advantage of FOZ approach over T-Rional?
I'm sorry, I missed what you said.
What is the advantage of fronto-orbitozygomatic approach over conventional T-Rional approach?
Again, I think, basically, if you look at the old literature, particularly the subfrontal approach from the 1980s, they talked about a lot of significant cognitive dysfunction, particularly in executive function in their patients 5 and 10 years out. Boston Children's series from Shillito and his colleagues at that time, made a plea for partial resection using the subfrontal approach. I think, it's the same principle as any skull base operation. That is, the less retraction, you do, the less likelihood you are to injure normal structures. You know, I am a product of the Yassergill generation. And so this approach was what I was comfortable with. By removing the roof of the orbit, you're able to get a flatter approach and do less frontal retraction. And I think we've seen that when we're doing our neuropsychological test, which I didn't show you that data, we had almost zero executive function deficits. So I do believe the less or the least frontal lobe retraction, the better. Now, having said that, I know there are people who are masters of a standard pterional approach. There are people who are masters of a subfrontal approach where they're able to get adequate relaxation and do the entire case without any retraction at all. So again, I think if any given surgeon has the experience and technical abilities to go from a different venue or avenue, I have no problem with that. This is just what I have found works well for me and for my patients.
Thank you, Dr. Wisoff. In terms of the transsphenoidal, extended transsphenoidal approach versus a transcranial approach, is there any particular case, which case that you will refer the patient to transsphenoidal rather than you doing transcranial, and which operation that you would say to someone who's doing extended transsphenoidal, they should probably give it to transcranial things?
Sure. I think almost everyone is capable of removing a 2 centimeter intracellular tumor. As long as you have the diaphragma above you, it protects you from the circle of Willis. And that's my major concern about the transnasal approaches. The advantage of a craniotomy is you see the vessels early on and you have vascular control and you're dissecting away from the vessels. Going from below the transnasal approach, the vessels are hidden initially. So you have to get around the tumor before you know where the vessels are. If your tumor is purely below the diaphragmacellae, you're safe. You can go transnasal and you don't have to worry about the vessels. And I think that's a very good approach. I think as I look at my series over time, for whatever reason, more and more of my patients have become retrochiasmatic. And I suspect that's because the prechiasmatic ones are the ones that everyone else enjoys doing and they feel comfortable doing, and they never make it to see me as a consult. In terms of the extended transsphenoidal approach, I think that then comes to the experience and a very, very sharp learning curve. Once you get above or outside of the diaphragma, you're dealing with a level of complexity, technical knowledge that is an order of magnitude above that intracellular. So that, I would say, really comes down to an individual's or an institution's experience. In terms of those that I think are not best managed from below, I think it's the ones that spill into multiple CSF cisterns. I have tumors that have gone from the foramen of Monroe down to the pontomedullary junction, which are all accessible through an extended pterional approach. But I think it'd be extremely difficult to get these from a transnasal approach. And to me, it actually makes little sense to drill out the entire clivus and create potential instability on that. So that would sort of be how, as I would differentiate it. Intracellular, definitely transnasal. Infradiaphragmatic, probably transnasal if you're experienced. Extended transnasal, you need a very significant degree of experience and a good team to do that. And multiple compartments, probably best still approached by craniotomy.
That's great. Thank you. Can I just invite Dr. Ramirez, Alma Ramirez, she's senior pediatric neurosurgeon, I'm sure you know, from Mexico. Dr. Ramirez, do you have any questions for Dr. Wisoff?
Yes, congratulations, because it's a really interesting term about the craniopharyngiomas. We now here in Mexico performance research about the craniopharyngiomas, because we development surgery in pediatric patients and my colleagues in adults observed these patients along the life, and I want to know more about the quality of life scores for evaluation this patient in and along the life.
I'm sorry, I just lost you.
Sorry, Dr. Ramirez, we lost the last sentence.
Oh, I want to know more about the quality of life scores for evaluation the pediatric patient with craniopharyngiomas.
Sure. So, we try to look at it two ways, which is the data I showed you. The first is looking at them within the first 5 years. And that was the more robust data that we had quality of life data on nearly 90% of our patients in the first 5 years. And within that time, statistically, they were all working within the normal range in terms of the quality of life measures we used, the Achenbach checklist and the child life survey. What we did see, though, is that within the normal range, they were at the high end or low, or rather, they were at the low end of normal in several areas, school, physical activities. So, and when you try to say, well, why is this? Why are they normal, but they have these tremendous differences in the subtests of quality of life? A lot of that comes back to the problems of chronic disease. This is the same pattern that as I mentioned, that you see in a child with juvenile rheumatoid arthritis, a child with badly controlled juvenile diabetes mellitus, a child with kidney disease, that the frequent hospital visits, the frequent physician visits, the need for ongoing medication, that in and of itself adversely affects the quality of life, so that superficially they look normal, statistically they're normal, but within the statistical analysis, you see the trends towards certain areas that are affected. And that was actually not exactly what we expected when we did the survey. We thought we would see a lot more problems that were related to either a neurologic deficit or visual deficit. Not really. The things that patients complain about is mostly the impact of constant medical care. And we saw that both in those children who had radical surgery and those children who had partial resection and radiation. It was that constant need for medical care and their uncertainty of the future that impacted the quality of life.
Thank you. Is that okay, Dr. Ramirez? Dr. Wisoff, I have got a few questions before I come to the question of Dr. Maurya. In terms of, in many countries, you are working in a different system to many European countries, certainly different from UK, where centralization has been the the philosophy, or a contested philosophy in UK. I'm sure you are so close to UK that you know this very well. The question is that is centralization absolutely important? And why I'm asking this question is that I don't have any bones on this because I'm not doing craniopharyngioma and don't plan to do it. But the adult neurosurgeon, you used to have a big vascular practice, so for you to go transcranial was a natural extension, I would think so. And the adult neurosurgeons are vascular neurosurgeons, skull-based neurosurgeons, and should a patient need to go to a centralized place, or in every department with a joint pediatric and adult surgeon who's familiar in this microneurosurgery good enough? Thanks.
That's a very good question, a very hard one to answer. Obviously, I live in a country where there is very little, if any, centralization, and very little, if any, logical triage of patients. And I am an advocate for going to a place where you do have experience. I don't necessarily think that it has to be an adult skull-based surgeon who's doing 40, 60, 100 skull-based cases a year, because I do believe there are nuances to handling the pediatric brain, and more than nuances in philosophy. Again, adult neurosurgeons are looking in 3, 5, 7-year survival and outcomes. The majority of adult brain tumors are in older patients, and the benign ones, they're not looking for 70-year survival, or they rarely are. So I think there is a philosophic difference. It's the same philosophic difference that I think drives us to not always doing radical surgery. And I really hope I did not come across as an evangelist for radical surgery, but rather just to say that this is within your armamentarium. I think in countries where it is possible to triage and centralize, it is advantageous. I know in the UK that's now been done for epilepsy surgery for similar reasons. The adult epilepsy people are, 1% of the population is potentially a candidate for epilepsy surgery among the adults. So they have huge numbers, but they don't necessarily have the same concerns as pediatric practitioners do. So I think centralizing to a few pediatric centers rather than taking on adult surgeons who may not have the right philosophic or the excellent technical abilities. I think the middle of the road approach would be a team approach where you have a pediatric neurosurgeon with a modicum of experience operating in the suprasellar cistern, with knowledge of how to deal with the pediatric brain, with a philosophy for long-term outcomes, working hand in hand with an adult skull-based surgeon as a coach or mentor or co-surgeon. So I think that would be the way I would look at it and think about it. I would not like to see this suddenly go totally to the adult world by saying, well, they do so many more than we do. I don't think their outcomes are necessarily going to be better. I think the pediatric philosophy and some of our pediatric technique is beneficial, and to work collaboratively would be beneficial where it's appropriate.
Thank you. On the same track, I know this is slightly different from the topic of your lecture, but I think it would be good to get your view on it. In terms of a high volume center, you mentioned 5 cases a year, and so what's the for example, someone who's doing 1 or 2 would say, what's the difference between 2 and 5, or is it 3 and 5? And where do you see, for example, if it's pituitary tumors, I can't, in my days when I was training, you have to be 200 tumors to consider yourself a pituitary surgeon. So what's your thoughts on the numbers per year for this operation?
Sure. Well, I think our initial experience we gained during our training, your 6, 7, 8 years of training is the opportunity to be exposed, to gain initial experience. And again, because you'll be working a great deal on adults, where you will be operating the suprasellar cistern, perhaps not as much as in the past. Again, I grew up in the era of micro-neurosurgery and microvascular surgery. So as you mentioned, a lot of my early training was in clipping aneurysms, and that provided the foundation for my technical advances in this area. The number 2 is a number that came up. The late Alex Sanford surveyed neurosurgeons, pediatric neurosurgeons in the United States, and looked at their outcomes. And it seemed that if you did more than 2 a year, your outcome was twice as good as if you did less than 2 a year. It's a very arbitrary standard. I think the best situations where you are doing a number of lesions in the suprasellar cistern, both transcranial and transnasal, so that when you combine, optic pathway tumors, suprasellar epidermoids, pituitary adenomas, again, each of them being relatively unusual, but together you get a reasonable number of cases that you'll be doing a little less than 1 case a month, which keeps you facile in this area. I don't know if that's a good answer or not.
I think I think the numbers are, as you said, not many. So I think it's having that experience. That would be great. Just 3 technical questions, if I may ask you,
Sure.
as in technical, as in not operative technical, but more specific. You are using the Puget classification, and what would you say the advantages, disadvantage of Puget versus Liverpool classification?
I mean, the Puget is simple. It's easy. The radiologist can get it right. I think the Liverpool is a good one also. I think the Puget has the advantage that it was validated with a prospective cohort, as well as the retrospective. The numbers are a little bit more robust. Do I think it's the final answer? No, but I think I think it highlights the role of the hypothalamus. I've reviewed a number of different articles that have looked at other statistical methodology to try to predict the risk of hypothalamic damage. Some of these are manuscripts in preparation, so I don't want to go into details. I think there'll be other classifications. I think ultimately it has to be relatively simple. There's a recent paper from Boston that talked about the type of cyst and the likelihood of resection. I think there are other things you can look at. This is obviously one factor. And as I mentioned, it is a crude measure because we still have a significant number of patients who are injured, even with the Puget classification and with hypothalamic sparing surgery. In their series, it was still 28%. And there are other patients who appear the same radiographically who you can do the surgery and not have a problem. So I think there's a lot more that needs to be investigated here, a lot more research. And I hope that people will work in collaborative groups, consortium. Todd Hankinson from University of Colorado, Denver Children's Hospital put together a consortium looking at craniopharyngioma. And I think these are the ways we'll get some answers for these rare diseases.
Thank you. The other question from one of the participants was about interferon injection. Have you ever subscribed to it, or is there a patient that you would prefer them having a interferon administration into the cyst? Thank you.
Sure. I think it's an effective therapy. The problem is when you look at the long-term data, roughly 2/3 of the patients have progression over time. But I do think it's a potentially curative therapy. If you have a purely cystic tumor, and particularly a thin-walled cyst, those are probably anatomically the ones that are the best suited for intracystic interferon. Personally, I've used it mostly in recurrent tumors, recurrent cystic tumors. And I find in those that we have similar results. About 1/3 of them, we have long-term durable responses for the cyst, but not necessarily the solid tumor. And about 2/3 after discontinuing the interferon, there will be progression.
Thank you. There was another question from Dr. Maurya in terms of at what point you would stop doing reoperations. I think it was 2, was it? One recurrence you would stop?
Yeah, generally I've tried to do 1 recurrence if I'm going for curative intent. There are times when we end up doing palliative surgeries, and we've done multiple resections in children where everything else has failed. These are not children where we're anticipating good outcomes. It's a bit like resecting a glioblastoma that multiply recurs. With each re-resection, you will get some benefit, but the durability of the benefit diminishes. I think it's, and that becomes a case-by-case scenario. Where is the tumor growing? Particularly, is it involving the vessels? Can you debulk enough away from the vessels to give relief and perhaps create a target for radiosurgery? Sort of a separation surgery that removes it from the optic chiasm. I think those are a lot of the questions we ask when we're doing a multiply recurrent tumor. And again, those are either palliative or bridge to some adjuvant therapy.
That's great, thanks. If you can, please be with me for the next 5 minutes, just quick 5 questions. Any thoughts on intraoperative MRI and visual Evoke potentials during surgery?
Sure.
And last one would be.
Sure. We've tried optic visual potentials. We have not been able to get consistent results. I think there are some centers that have become masters at visual Evoke potentials, and if they can get consistent results, I think that's terrific. Part of the issue is that at least 1/3 of children present with significant visual impairment, so that the potentials are just not achievable. I think Evoke potentials still in many centers are an art rather than a science. If your center has the art where you can get reliable potentials, I think it's worthwhile. I would not consider it a standard of care. I'm sorry, I forgot the other half. The
intraoperative MRI.
We use the intraoperative MRI. We've had it for 3 years now. It's nice. I get the scan at the end and confirm that I got out what I thought I got out. It's nice that for younger children, we don't have to sedate them for a post-op image. But I by no means do I think it's critical.
Thank you. The very last question, Dr. Wisoff. In terms of severe hyperphagia, how have you managed them? Is it functional neurosurgery, medications? So recently there were medications for hyperphagia. What's your thoughts and your colleagues in endocrine?
Yeah, it's a disaster. I can name all 5 of them, 5 patients with this, one of whom has, I think now weighs roughly 470 pounds. And that particular young woman, who's actually working as a teacher, had functional neurosurgery, had stereotactic implants into the hypothalamus that were not successful. There was a drug that was being looked at that was a leptin analog that seemed to be effective. It was first tried in Prader-Willi syndrome. Unfortunately, it ended up having a very high incidence of thrombotic complications and thrombophlebitis and pulmonary embolus. So that was pulled before it went to market. There are some other newer drugs that are looking to address hypothalamic dysfunction, a number of forms of obesity. I think the jury is out on whether they will be effective when you have this type of hypothalamic injury or not. I think the future is definitely the development of a leptin analog. I think that will resolve the majority, but not everyone. Milder degrees of obesity, so let's say BMIs of 30 to 40, there have been a number of reasonable diet programs that have brought patients down to under 30. Not that they are normal, they're not under 25, but they're definitely no longer in the group that has the highest risk of long-term medical complications.
That's great. Thank you very much, Dr. Wisoff. It was a fantastic lecture. I think it was, and as you said, it was a very balanced and that's one of the things about you. I have had the privilege of discussing over many years about everything, and you always have a holistic approach, and you have your preference, but you don't you have a very balanced view of things. So that's really very unusual for someone with a specialist interest, because thank you very much for the fantastic lecture and the discussions. I hope I think have been appreciated in the participants' comments as well. So great honor to have your privilege, and we have all learned. And the lecture will be available in few minutes in YouTube as a recording. So anyone who wants to review it can review it. Anyone who missed because of their clinical commitments can review it, and it will be a great resource. Thank you very much, and wishing you a great day, Dr.
Thank you again for the honor of talking. Take care.
Thank you. Bye for now. Thank you very much. Thank you. Thank you very much, all the participants. Thank you very much.
I managed to attend despite of my anxiety. Thank you. Enjoyed.
Very welcome.
Thank you.
Thank you, sir.
Oh, thank you. Thank you very much, Dr. Maria. Great questions.
Thank you, sir.
Thank you. Thanks, Dr. Ramirez. Thanks for great to have you. Brilliant.
Narendran, sir, I managed to put that question in front of sir when your internet connection was not working. So
oh, which one?
That FOZ versus Tyrionel. So by the time you rejoined, he was answering the same question.
Yes, that's brilliant.
Thank you, sir.
Excellent. Thank you very much, everyone. Have a great day.
Thank you, sir.
Which part of the world you are. Take care.
Thank you.
Thank you.